Good morning, ladies and gentlemen. Welcome to this first webinar from the European Menopause and Andropause Society, EMAS. We are happy to announce that we have 200 attendees in our first webinar. The speaker that we have today is the Professor Irene Lambrinoudaki from Greece, President of the European Menopause and Andropause Society. We hope that you enjoy his speech about when and how to prescribe menopausal hormone therapy.
I would like to welcome you in this webinar series EMAS has introduced with the aim of discussing practical issues related to the care of women and men in middle age. Our first topic is when and how to prescribe menopausal hormone therapy. We're going to have first the presentation, and afterwards I will be happy to answer and discuss your questions. So, menopause is the permanent cessation of menses due to ovarian follicle exhaustion. This has two consequences. First, the loss of reproductive function, and most importantly, estrogen deficiency. And all the pathology we are going to discuss later has its origin in this postmenopausal estrogen decline. What are the consequences of menopause? There are the short-term consequences, consisting of menopausal symptoms, hot flashes, night sweats, mood disturbances, sleep changes, muscle and joint pain, sexual dysfunction, urogenital atrophy, but most importantly, we have the long-term consequences of menopause, consisting of cardiovascular disease, osteoporosis, and cognitive decline. In light of this background, we have three categories for prescribing menopausal hormone therapy. The first group is the premature ovarian failure women, women whose period has stopped below the age of 40 years of age. We have the perimenopausal women, those who have menstrual irregularities, and those who are up to 1 year after the last menstrual period. And the third group is the postmenopausal women. Concerning the first group of women, we're not going to go into detail because this is the topic of a special webinar. In general, these women with premature menopause have a higher risk of many diseases like cardiovascular disease, osteoporosis, cognitive decline, mood disorders, and premature death. Therefore, we should prescribe menopausal hormone therapy to all these women, independently of the presence of menopausal symptoms, exactly the same way as we prescribe hormone replacement to any endocrine gland failure, like hypothyroidism. And the duration of use of hormones to these women should be until the age of natural menopause. Concerning the two other groups of women, the perimenopausal and postmenopausal women, the indication of menopausal hormone therapy for these women are the presence of menopausal symptoms, as we said before, hot flashes, sleep difficulties, mood swings, muscle and joint pain, sexual dysfunction, and the presence of the genitourinary syndrome of menopause or urogenital atrophy. And of course, another indication is the prescription for prevention of osteoporosis at symptomatic women who are at high risk of sustaining an osteoporotic fracture. There is not one regimen which would prescribe to all women in the perimenopause and postmenopause. We have to individualize hormone therapy. We have to evaluate the patient. We have to define the timing of initiation, the duration of use. We have to select the regimen with respect to estrogen dose, progestogen type, the mode of delivery, and the route of delivery, so that we have a maximal efficacy of our treatment concerning quality of life, osteoporosis prevention, and cardiovascular disease prevention, and at the same time, not to have clinically relevant risk concerning breast cancer and thrombotic events. When prescribing menopausal hormone therapy, we have two broad groups of women. Women who have removed their uterus, and here our life is easier because we can administer estrogen-only therapy or Tibolone, and women who have an intact uterus. So these women should receive estrogen plus progestogen or Tibolone or estrogen plus a SERM. Concerning the estrogen part of hormone therapy, we may give our treatment as a daily tablet, as an oral daily tablet, once daily. 17-beta estradiol, which is the natural steroid produced by the ovary, or esterified estradiol, or conjugated equine estrogens. We may want to give our treatment transdermally, as a patch, twice weekly, or as a gel, usually once daily. And if we have only symptoms of urogenital atrophy, we can give our treatment transvaginally, either as a ring or a pessary, usually once every 3 months, or as a tablet or cream. Usually we start with daily administration for a couple of weeks, and we proceed with maintenance therapy once or twice weekly. And we can again use 17-beta estradiol or conjugated equine estrogens or the weaker estrogen estradiol. Concerning the progestogens, we have a variety of compounds to use here. As their name implies, the progestogens have the capacity of inducing a spreader endometrium, and they are divided into natural progesterone, which is produced by the human ovary, and into synthetic progestogens, which are also called progestins. Progestins are further divided into those structurally related to progesterone and those structurally related to testosterone. In the first group, among others, belongs the MPA, the progestogen which was used in WHI, dydrogesterone, and the cluster of progestogens mainly used in Central Europe, named norpregnant derivatives. And in the second group, among others, belong the norethisterone acetate, levonorgestrel, dynogest, and drospirenone. Progestogens are not all the same. They do not exert the class effect. Their activity depends on the molecule. For example, drospirenone has also antimineralocorticoid activity as well as progesterone, while MPA has weak glucocorticoid activity and levonorgestrel has weak androgenic activity. So depending on the progesterone we choose, we alter the activity of our regimen. Tibolone is a selective tissue estrogenic activity regulator, which means that it has estrogen, progestogen, or weak androgenic activity depending on the target tissue. This is an old medication which is available in Europe only since 1989, and it is indicated for the management of menopausal symptoms and urogenital atrophy only in postmenopausal women. This is not a medication for perimenopausal women. The combination of estrogens plus SERM consists of a low-dose preparation of conjugated equine estrogen plus 20 mg of vasotoxin. This is an oral preparation which is administered once daily, and it is indicated again for the management of menopausal symptoms and urogenital atrophy only in postmenopausal women who have contraindications to receive a progestogen or are intolerant to progestogens. We have reviewed the compounds we used in hormone therapy. Now we will review the dose. Usually in perimenopausal and postmenopausal women, we start with a low dose, which consists of 1 mg estradiol per dose or 25 micrograms estradiol transdermally. If we do not have symptom control with this dose, we may increase the dose to standard dose, which usually is used in younger women. And on the other hand, if we have good symptom control with this dose, we may, after a couple of years, switch to ultra-low dose, which is 0.5 milligrams oral estradiol or 14 milligrams of transdermal estradiol. Concerning the route and the mode of delivery, we have already discussed the estrogen part. Concerning the progestogens, we can give the progestogen continuously, without stop. This will ultimately lead to amenorrhea, and this is a regimen which is used only for postmenopausal women. Or we may use the progestogen sequentially every 10 to 14 days per month, and this will produce a withdrawal bleeding after the cessation of the progestogen. We have the option of the intrauterine device of levonorgestrel, which is placed once and it is active for 3 to 5 years. Which are the benefits of menopausal hormone therapy? The benefits is the management of all conditions who have their origin in the postmenopausal estrogen decline, menopausal symptoms, urogenital atrophy, and most importantly, if we use in a proper way our treatment, then we have prevention of cardiovascular disease and osteoporosis. Let's go into detail into these last two conditions. The pathogenesis of postmenopausal osteoporosis lies in estrogen decline, which will lead in activation of osteoclasts and at the same time to decreased bone formation. These two processes will lead to low bone mass and deterioration of bone architecture and eventually to low trauma fracture. Therefore, the European guidance for the treatment of osteoporosis states that hormone therapy is among the only treatment that can reduce the risk of osteoporotic fracture, both the vertebral ones and the non-vertebral ones, including the hip. In high-risk group, this is true for other medications only, but also in the general population. So, in the first decade after menopause, when we have a high bone turnover due to estrogen decline, when we have a higher risk of vertebral fractures and the thrombotic risk is low, this is the best frame to administer hormone therapy for the prevention of postmenopausal osteoporosis. Concerning the other long-term consequences of menopause, the cardiovascular disease. The menopausal estrogen decline produces both direct and indirect effects on the vasculature. The direct effect is an increase in chronic inflammation, endothelial dysfunction, and an increase in arterial stiffness. Indirect effects, among others, include visceral adiposity, dyslipidemia, insulin resistance and propensity to diabetes mellitus, high blood pressure, and a state of chronic inflammation. All these processes will lead to atherosclerosis and ischemic heart disease and stroke. Today, we tend to recognize that women with hot flashes have also an unfavorable cardiovascular profile. So it is in these young, recently symptomatic postmenopausal women that hormone therapy will exert a favorable effect on cardiovascular risk factors. It will improve their lipid profile, their body composition, it will reduce insulin resistance, and it will reduce arterial stiffness and chronic inflammation. On the other hand, if we administer hormone therapy to older women who already have mature atherosclerotic plaques, this therapy may destabilize these plaques and cause an acute thrombotic event. So when prescribing menopausal hormone therapy, we have to make use of the window of opportunity. If we administer our treatment to the first group of women with early atherosclerosis, we'll improve vasodilation, we will reduce inflammation, and we will retard the lesion progression. On the other hand, if we administer therapy on the other group of women with established atherosclerosis, then we will do harm, we will prevail, the harmful effect will prevail, and we will cause a thrombotic event. This is very elegantly shown in many epidemiological and clinical studies on hormone therapy, like the Danish osteoporosis prevention study, where women who started early menopausal hormone therapy had a 50% reduction of mortality, heart failure, and myocardial infarction. In a very recent study in Finland, on 500,000 women who received hormone therapy between 1994 and 2009, it was evident that these women had a coronary heart disease reduction between 18 and 50%, and at the same time an increase in life expectancy by 12 to 40%. And what was most important is that there was a linear association between this effect and the duration of use, meaning the longer they used hormones, the better their life expectancy was. This year, a Cochrane review came about with the question whether menopausal hormone therapy can reduce the risk of cardiovascular disease in women. The answer is no in the general population, but the effect of hormone therapy depending on hormone therapy timing. Women who started therapy within the first decade after menopause had a 50% decrease in coronary heart disease and a 30% reduction in mortality. In light of this evidence, how do we initiate hormone therapy according to cardiovascular risk? We have some groups of women who are high cardiovascular risk, and there we should not use hormone therapy, like women who are over 60 years of age, women who have menopausal age for more than 10 years, women with long-standing poorly controlled diabetes, or women with clinically overt cardiovascular disease. We have women with intermediate risk, like women with risk factors such as dyslipidemia, obesity, smoker, hypertensive, diabetic women. Here we can use hormone therapy, but we should prefer the transdermal way, which has a far better cardiovascular risk profile. And finally, we have the low-risk women, which are the majority of women after the menopause, and there we can use any type of hormone therapy. In the last slides, we're going to review the risks of hormone therapy, consisting of breast cancer and thrombotic events. I'm sure you're all familiar with these figures. From epidemiological and RCT studies, we know that hormone therapy is associated with 25 to 30% increase in the relative risk of breast cancer. This is equivalent of about 3 more women per 1,000 who will use hormone therapy during 1 year. The figure, of course, is very small, but we can either make it negligible on clinical grounds by evaluating women and by selecting the hormone therapy regimen. Conditions which do interact with hormone therapy is the very low body weight, the daily alcohol consumption, and the high mammographic density, usually level 3 and 4 on the ACR rating systems. Risk factors of breast cancer which do not interact with hormone therapy is obesity, the family history of breast cancer, low parity, and a history of breast surgery for benign condition. Breast cancer risk indeed depends on the regimen we're going to select, and the most important factor is whether we use estrogen monotherapy or we use combined estrogen-progesterone therapy. After that, we have the duration of use, the type of the progestogen, the mode where we administer our therapy sequentially or continuously, and the dose. There's much evidence, both epidemiological studies and RCTs, which shows that estrogen monotherapy is either not associated with breast cancer, or if it is to a much lesser degree. Here is the latest analysis of a WHO trial, where it is evident that an increased risk is in only in women who use the combination of estrogens plus MPA, while 7 years of continuous use of estrogen monotherapy do not increase the risk of breast cancer. The second issue is the choice of the progestogens. As you see here in this experimental study, the breast cell proliferation rate is much higher with the combination of estrogen plus medroxyprogesterone acetate compared to the combination of estradiol plus macronized progesterone. In this large French epidemiological study, which consists of 80,000 postmenopausal teachers who were followed up for a mean of 8 years, it was evident that estrogen alone or in combination with progesterone or progesterone had a much lesser effect on breast cancer compared to the combination of estrogen plus all other progestogens. And this differential effect was evident across all levels of duration of use. So, up to now, we have 3 epidemiological studies to show that natural progesterone and dydrogesterone have a better risk profile with respect to breast cancer compared to the other progestogens. The other issue is the mode of administration. We have 7 big epidemiological studies which all show that sequential hormone therapy is associated with a lower breast cancer risk compared to the continuous regimens. And this makes sense because cumulatively the exposure of the breast to progestogen is much less with sequential therapy compared to continuous therapy. So how do we customize our regimen in the context of breast cancer? We have to use the lowest effective estrogen dose combined with natural progesterone or dydrogesterone or a serum in a sequential mode of administration, and we have to annually perform cost-benefit analysis and estrogen dose setting. We will finish reviewing the thrombotic risk. It is known that oral menopausal hormone therapy increases the risk of stroke in all ages slightly but significantly, and the possible mechanism is the clotting factor induction through the first pass effect of the hormones in the liver. Of course, when we speak of young, recently postmenopausal women, the absolute risk is very small, but in the presence of risk factors, the risk becomes clinically important. The same is true for VTE, for venous thromboembolism. Oral hormone therapy increases the risk of VTE much higher compared to stroke by 2 to 3-fold, again by the same mechanisms. Today, we have good epidemiological evidence to show that the use of transdermal hormone therapy may not increase the thrombotic risk, and furthermore, this risk may depend on the type of the progestogen. As you see here in the large case-controlled study conducted in the UK, low-dose transdermal hormone therapy is not associated with an increase of stroke risk, either if it is used alone or in combination with a progestogen. The same is true for venous thromboembolism. In this French case-control study, it was again evident that the use of transdermal estrogen does not increase the risk of venous thromboembolism. And most importantly, the increased risk was seen only in women using the cluster of non-programmed derivatives. Exactly the same results were obtained from the Irene study I showed you earlier. Transdermal estrogen do not increase the risk of VTE, and again, all the increased risk was seen in the women receiving non-programmed derivatives. In the latest analysis of the Million Women study, it was a large observational study on 1 million postmenopausal women residing in the UK. It came out that the incidence of venous thromboembolism over 5 years of observation was different according to the regimen. The worst combination appeared to be oral estrogens plus medroxyprogesterone acetate, followed by oral estrogens plus norepinephrine levonorgestrel, and the oral estrogen-only regimen was far better with respect to VTE. How do we prescribe hormone therapy in the context of VTE? We have to carefully screen for risk factors, personal family history of venous thromboembolism, increased age or menopausal age, obesity, immobilization, the presence of diabetes, smoking, and we have to choose our regimen. In women without risk factors, we can choose any regimen we want. But in women who have risk factors for venous thromboembolism, low-dose transdermal estradiol should be our choice. And this is my last slide. This is the concept of menopausal hormone therapy in menopause. We have to make use of the window of opportunity. We have to start early, either in perimenopause or early postmenopause, usually with low-dose hormone therapy, and after a couple of years, we may switch to ultra-low dose. And the duration of use is a personal choice who has to be made combined by the prescribing physician and the individual woman. Thank you very much.